Right now, engineers are actually using the exact same fiber optic sensors that they deploy to stress test things like suspension bridges or, skyscraper foundations, but they're using them to map the structural integrity of the human vagina.
I mean, I know it sounds completely like science fiction, right? But treating the pelvic floor as an actual load-bearing architectural structure, it's it's fundamentally changing sexual medicine.
Yeah, it really is.
Because for a long time, we just viewed sexual function through like a purely psychological lens
Yeah.
or maybe vascular, blood flow.
Right, exactly.
But now we're literally translating it into the language of mechanical engineering. We're analyzing tensile strength, shear forces, material elasticity.
And that is kind of the core of our mission for this deep dive. We're exploring the hidden biomechanics of the pelvic floor and, decoding how the vaginal wall functions under just immense physical stress.
Oh, definitely. The forces involved are incredible.
Yeah. And we'll be analyzing how medical interventions physically alter that landscape, to restore sensation. We're pulling this analysis from a really fascinating stack of sources today for you.
It's a great collection of data.
We've got finite element modeling of pelvic tissue, biomechanical research on tissue elasticity using animal models, and even clinical trial data comparing injectable fillers, things like cross-linked hyaluronic acid and platelet-rich plasma.
Which is such a massive leap from how we used to study this.
Right. The goal here for you listening is to look at human pleasure not just as like an emotion, but as a measurable physical transfer of kinetic energy. So, okay, let's unpack this. To understand how clinicians are attempting to augment or reinforce this tissue, we kind of have to look closely at the architecture of the vaginal wall itself and, what happens when it undergoes the ultimate stress test.
Right, which is childbirth. And when you look at the vaginal wall at a microscopic level, you are basically looking at a highly sophisticated composite material.
Like carbon fiber or something.
Yeah, exactly like that. It relies on this dense extracellular matrix, which is primarily composed of collagen and elastin fibers. And this specific biological weave, it has a sort of dual mandate.
Okay, what do you mean by dual mandate?
Well, it has to be incredibly compliant to allow for, massive expansion, but it also has to be resilient enough to snap back and maintain its baseline structural tone afterwards.
But childbirth completely disrupts that matrix, doesn't it?
Oh, absolutely. During a vaginal delivery, the tissue is subjected to extreme mechanical strain. I mean, strain that often completely exceeds its physiological limits.
Right. And the research we're looking at highlights that this trauma frequently results in a condition known as vaginal laxity. And I mean, the numbers here are just striking.
They really are.
Yeah, there was a global survey indicating that 83% of urogynecologists identify vaginal laxity as a severely underreported condition.
Which is wild when you think about how common it is.
Exactly. And it physically diminishes both tightness and friction, which leads to a marked decrease in sexual sensation. Yet, because it isn't always classified as like a severe prolapse where organs are shifting dangerously, it just often gets dismissed.
Right. Women are basically told, it's just a normal part of having a baby.
Yeah.
But to map the exact molecular mechanics of that laxity, researchers have actually relied heavily on animal models.
Because getting tissue from humans is tricky, right?
Yeah, incredibly
Yeah.
difficult. Obtaining healthy, full-thickness pelvic tissue samples from living women without pre-existing pelvic floor disorders is incredibly invasive. It's just very rare.
So they use mice instead.
Yeah, biomechanical engineers frequently turn to mice to isolate the variables of pregnancy and childbirth.
Okay, so the specific study in our sources, they compared wild-type mice with, I'm going to get this name right, FBLN5 knockout mice,
Yep, you got it.
which is a strain genetically engineered with a severe elastic fiber deficiency, right?
Exactly. And by using that specific knockout strain, researchers could observe what happens when the baseline elasticity is already compromised before pregnancy even happens.
Oh, wow, okay.
Yeah. And then they measure the compounding effect of the pregnancy on top of that.
Yeah.
The data showed that pregnancy itself confers highly measurable permanent alterations to the vaginal wall's structural properties.
Permanent alterations, that's a big deal.
Huge. They tracked metrics like tissue length at failure, maximal strain, and overall tissue stiffness. And post-pregnancy, the vaginal tissue exhibited significantly increased distensibility, meaning it stretched much further under the exact same amount of force.
Right.
Alongside a really marked decrease in both tissue stiffness and maximal stress tolerance.
Okay, so if I'm picturing this for you listening, I picture the pre-childbirth vaginal wall kind of like a fresh, tightly woven bungee cord,
Oh, that's a really good way to visualize it.
Yeah, like it stretches, but the internal resistance is really high and it has this aggressive snapback. But the post-childbirth wall, especially after significant trauma, it behaves a lot more like a bungee cord that has been left holding a heavy load for way too long.
Exactly. It's all stretched out.
Yeah, the micro tears in the elastin fibers mean it still functions as a cord, but it completely lacks that inherent stiffness. The resistance to kinetic force is just fundamentally lower.
And that loss of intrinsic resistance is exactly what drives the clinical symptoms of laxity, the feeling of looseness. But to treat it mechanically, you have to be able to measure it mathematically.
Which brings up a big question. If this is a physical structural change, how are doctors actually measuring it? Is it just based on patient feelings, or is there like an actual ruler for this?
So historically, gynecology basically relied on the POPQ system. That stands for pelvic organ prolapse quantification.
Right.
And it measures how far specific anatomical landmarks has physically descended relative to the hymen during a Valsalva maneuver, which is like when you bear down.
But the issue with POPQ, based on our sources, is that it only maps position, right? Not the material quality of the tissue itself.
Exactly. It tells a doctor that the tissue has dropped, say, 3 centimeters. But it offers zero data on the tensile strength, the distensibility, or the actual biomechanical forces acting within that tissue.
Right. It doesn't tell you how weak the bungee cord is, just that it's hanging lower.
Perfectly said. And that glaring blind spot is why we are now seeing those structural engineering tools brought directly into the clinic.
Like the bridge sensors.
Yeah. So one approach is urethral pressure reflectometry, or UPR. This utilizes sound waves to measure the cross-sectional area and opening pressures of the urethra.
Which is pretty advanced, but they go even further than that, right?
Oh, way further. The biomechanical profiling is getting wild. Researchers are now deploying in vivo vacuum probes directly onto the vaginal wall.
Okay, vacuum probes. Inside the body.
Yep. They apply a highly calibrated suction force to the mucosa, and then they use these tiny high-resolution cameras to measure the exact millimeter elongation of the tissue as it gets pulled into the probe.
Oh, wow.
And this actually provided quantifiable proof that the vaginal tissues of women without prolapse or laxity are exponentially stiffer than those suffering from it.
Okay, I have to jump in here. Wait a second. Fiber Bragg gratings and force sensors. Vacuum probes measuring millimeter elongation.
Yeah, it's intense.
It sounds like we are stress testing a suspension bridge, not a human body. I mean, aren't we overcomplicating something that is ultimately about human sensation? It feels a little aggressively clinical.
Well, what's fascinating here is that human sensation is an inherently mechanical process at the cellular level.
Okay, explain that.
We conceptually separate the physical force of intercourse from the neurological feeling of pleasure. But in biology, they are the exact same event. The mechanoreceptors embedded in the vaginal and clitoral tissue, they literally do not fire unless a highly specific threshold of physical deformation is reached. They require physical pressure, stretch, and friction to generate an electrical signal to send to the brain.
Oh, I see what you're saying. So if the tissue is highly distensible, if that bungee cord is loose, the physical force of penetration simply dissipates into the surrounding slack.
Exactly.
The mechanical threshold to fire the nerve is just never met because the tissue just moves out of the way.
You nailed it. The
Yeah.
force is absorbed by the compliance of the tissue rather than being transferred to the nerve endings.
Wow, okay.
And that is why capturing the dynamic pressure profile using these advanced tools like fiber Bragg grating sensors or Flexifor sensors is so vital. Fiber Bragg gratings use microscopic shifts in light wavelengths running through an optical fiber to measure bending and strain in real time.
It's just unbelievable that they can do that inside the body now.
It is. And by mapping the exact kinetic forces inside the vaginal canal, we finally have the blueprints to develop targeted therapeutic strategies.
Which brings us perfectly to the specific anatomical zone that most of these therapeutic strategies target for sexual enhancement, right?
Yes.
The anterior vaginal wall and, the enduring controversy of the G-spot.
Right, the famous G-spot. So the anterior or the front vaginal wall sits directly against the base of the bladder and the urethra. And for decades, the medical community heavily debated the existence of the G-spot, as a discrete anatomical entity.
Because they couldn't find a specific button.
Exactly. People were looking for a specific bundle of nerves or a distinct glandular structure that could be like neatly isolated during an anatomical dissection.
But the consensus in the modern anatomical reviews from our sources is that the G-spot isn't a button at all, is it?
No, it's not.
It is more accurately described as a functional clitorethrovaginal complex.
Yes, that's the current terminology. It is a highly interactive three-dimensional network. It comprises the internal crura of the clitoris, the urethra, and the anterior vaginal wall itself.
Okay, so it's a whole region working together.
Exactly, and the sensory capacity of this region relies entirely on indirect stimulation. Because the complex sits behind the vaginal wall, any kinetic energy has to travel through the wall to actually stimulate the underlying structures.
Right.
And anatomical studies show a direct, measurable correlation between the thickness of this urethrovaginal space and a woman's orgasmic capacity.
Okay, so I like to think of this functional zone kind of like the sweet spot on a tennis racket.
Oh, I like that analogy.
Yeah, because if you inspect the strings of a tennis racket, there is no raised bump or like special colored thread marking the sweet spot. It doesn't exist as an isolated structure that you can just pull out and hold in your hand.
Right, it's just strings.
Exactly, but it is a highly active functional zone where the specific mechanics of impact create this optimal resonance. When the ball strikes that exact intersection of string tension, the energy transfer into the frame is just perfect.
That's a great way to put it.
And the clitorethrovaginal complex operates on the exact same principle, right? It's the biological sweet spot where the mechanics of thrusting create the necessary structural resonance to trigger a massive neurological response.
Yes, exactly. But that resonance requires the tissue to have enough density and stiffness to actually transfer the kinetic energy. If the anterior wall is thin or highly lax due to childbirth, the energy transfer just fails.
The strings are too loose.
Exactly. The mechanical solution to this specific deficit is something called anterior vaginal wall augmentation, commonly referred to in the literature as the G-shot.
Right, and the clinical procedure for this is surprisingly straightforward based on what we've read. It takes about 15 to 30 minutes in an outpatient setting under local anesthetic.
Yep, very quick.
A physician uses a specialized speculum to inject roughly 1 to 2 cubic centimeters of a soft tissue filler directly into the submucosal layer of the anterior wall, specifically targeting that functional sweet spot.
And the literature heavily features two distinct injectable agents for this purpose. You've got cross-linked hyaluronic acid, or HA, and platelet-rich plasma, or PRP.
And they work a bit differently.
Yeah, they do. PRP utilizes the patient's own concentrated platelets and growth factors, so it's aiming for long-term cellular regeneration and neurovascular modulation.
Kind of healing the tissue over time.
Right. Hyaluronic acid, however, serves a purely structural role right away. It is a dense, viscoelastic gel that provides immediate mechanical support. It plumps the local tissue to about the size of a quarter.
And from what I read, the HA augmentation typically lasts about 4 to 9 months before it's naturally absorbed by the body.
That's right.
And the clinical outcomes, which they measure using the Female Sexual Function Index, they're significant. In one pilot study analyzing this augmentation, 87% of women reported enhanced sexual arousal and gratification.
Yeah, 87% is a compelling success rate. But the underlying mechanism of action is what makes this a literal masterclass in localized structural engineering.
Okay, here's where it gets really interesting. Because based on everything we've analyzed about tissue mechanics today, there's a specific biomechanical puzzle I want to explore with you.
I'm ready.
We know that a post-childbirth vaginal wall is often highly distensible. It lacks baseline stiffness. We also know that the clitorethrovaginal complex requires indirect stimulation through that wall.
Right.
So how does post-childbirth anterior wall laxity alter the perceived projection of the G-spot filler bolus during thrusting? Because my instinct is that injecting 1 to 2 cc of HA into a wall that is essentially a loose hammock would just result in the filler getting pushed aside.
Right.
Or squished into the surrounding compliant tissue, which would basically render it useless.
See, it's a highly logical assumption. If you push against a small object suspended in a loose net, the net just deforms and the object moves out of the way. But the physics of a cross-linked HA bolus injected tightly into the submucosal layer changes the local tissue mechanics entirely. It acts as an essential mechanical anchor.
Okay, so it creates a focal node of density in the middle of a compliant web.
Exactly the case. Imagine trying to push a hidden button by pressing your hand through a thick, loose feather pillow.
Okay, I'm picturing it.
The kinetic energy of your hand dissipates radially into all the feathers. The pillow deforms, it squishes, but the button underneath never receives enough targeted downward pressure to click.
Because the feathers just absorb it all.
Right, and this is exactly what happens during intercourse when the anterior wall suffers from extreme laxity. The energy from thrusting is dispersed across a wide, highly distensible area, completely failing to reach the firing threshold of the mechanoreceptors deep in the clitoretrovaginal complex.
So the HA bolus replaces the feathers with something solid.
Yeah,
It's like placing a dense wooden block inside the pillow directly over the button.
that is the precise mechanical shift. By injecting that dense, quarter-sized volume of HA, the physician artificially stiffens a highly localized zone of the urethrovaginal space.
Even if the rest of the wall is loose.
Exactly. Even though the surrounding vaginal walls remain highly distensible and loose due to the childbirth trauma, that HA bolus provides an immediate, dense kinetic bridge.
So during penetration, the thrusting forces no longer dissipate into the lax tissue. They encounter this firm projection.
Exactly. The bolus gives the thrusting forces a localized physical target to press against. And because the cross-linked HA is firm, it captures the kinetic energy and transfers it directly downward into the underlying clitoretrovaginal complex.
Wow.
It effectively bypasses the overall lack of tissue stiffness in the wider vaginal canal. The bolus doesn't get lost in the loose tissue. Its projection is actually enhanced by the surrounding laxity.
Oh, because it's the only stiff thing there.
You got it. It stands out as the single point of mechanical resistance. It restores the physical threshold required for sensory activation, which is exactly why 87% of those patients reported immediate improvement in arousal.
That makes perfect sense when you break down the physics of it. We've established how a localized intervention can profoundly change local sensation just by manipulating the physics. But the sources are also pretty adamant that we cannot view the pelvic floor as just a collection of isolated parts, right?
Oh, absolutely not.
Engineering a single node of resistance doesn't change the structural reality of the larger system. We have to look at how the entire pelvis balances these massive internal forces.
Yes, and this introduces the concept of dynamic biomechanical equilibrium.
Dynamic biomechanical equilibrium.
Right. The female pelvic floor is an incredibly intricate, interdependent web of muscles, fascia, ligaments, and organs. It has to maintain structural stability while constantly managing shifting intra-abdominal pressures, from breathing, lifting, coughing, exercising.
And the sources outline three major integrated components that maintain this equilibrium. First, you have a highly compliant bladder that can absorb and transmit stresses.
Right.
Second, you have the levator plate perineal body complex, which is a massive muscle group that generates a supero-anterior force, meaning it actively pulls upward and forward to close the pelvic hiatus and support the organs.
Exactly. It's the main hammock.
And third, you have the posterior fornix of the vagina, which basically acts as a structural fulcrum to help redirect all these kinetic forces.
And the interaction of those three components creates a very specific load-bearing architectural geometry.
Okay.
In a healthy pelvic floor, the interaction between the vaginal axis and the levator plate forms a precise 90-degree angle. This right angle is literally the secret to pelvic stability.
I really want to break down exactly how that 90-degree angle functions because this is where the structural engineering comparison is most literal for me.
Right.
It acts very much like an architectural buttress or a mechanical shock absorber.
It really does. So when intra-abdominal pressure spikes, say a woman laughs heavily or she lifts a heavy box, that kinetic force travels straight down vertically.
Right.
Now, the vagina rests horizontally on the shelf created by the levator plate muscles. Because they meet at that 90-degree angle, that downward vertical force hits a horizontal surface and is sheared backward. It's redirected safely into the rigid, bony structure of the sacrococcygeal axis, the tailbone.
So the force is just absorbed by the bone and the organs remain stable.
Exactly.
But if the levator muscles are damaged from childbirth and they lose their tone, that horizontal shelf drops, right?
Yes.
The 90-degree angle collapses and becomes obtuse, say, 130 degrees.
Correct.
Now, when that vertical downward pressure hits, it isn't redirected backward into the bone anymore. The force pushes straight down the vaginal canal, driving the organs outward, which is the mechanical cause of pelvic organ prolapse.
Precisely.
So what does this all mean? How does our 1 to 2 cc injection of hyaluronic acid fit into this massive dynamic equilibrium?
Well, if we connect this to the bigger picture, it really exposes the strict limitations of localized cosmetic or sensory fillers.
Right.
A G-spot augmentation is incredibly effective at solving a localized friction deficit. It alters the surface mechanics of the anterior wall to capture kinetic energy for sexual arousal. But it exists within and completely relies upon this larger, highly coordinated neuromuscular system.
Right. So a hyaluronic acid bolus is not going to restore a collapsed 90-degree levator angle.
It absolutely cannot.
Huh.
If the macroscopic dynamic equilibrium has failed, if the deep connective tissues are torn and the downward forces are no longer being redirected to the sacrum, a localized sensory filler will not stop the progression of prolapse. It won't cure the underlying systemic laxity.
It's a band-aid for the sensation, but not a structural fix for the whole pelvis.
Exactly. Fillers are a brilliant mechanical bridge for targeted sensory restoration, but long-term pelvic health requires the structural integrity of the entire load-bearing system.
It's basically the difference between replacing a frayed localized sensor wire on a suspension bridge versus repairing the main steel suspension cables that actually keep the roadway from collapsing into the river.
That's a perfect analogy.
Both are critical for the bridge to function as intended, but you cannot fix a failing main cable by just reinforcing a single sensor.
No, you can't. The macroscopic structure must be sound for the microscopic functions to thrive.
We have covered a massive amount of ground today, traveling all the way from the microscopic matrix of human tissue to the macroscopic physics of the pelvic floor.
It's a journey.
It really is. We started by looking at how the immense mechanical stress of childbirth permanently alters the elasticity and stiffness of the vaginal wall, breaking down the collagen and elastin networks.
And we saw how modern medicine is adopting the tools of structural engineers, right? Using dynamic vacuum probes and fiber Bragg grading sensors to quantify the exact intravaginal forces at play, proving that sensation is deeply reliant on physical tension.
Right. We mapped the functional sweet spot of the clitorethrovaginal complex on the anterior wall. And most importantly, we broke down the specific physics of how injecting a dense bolus of hyaluronic acid into a highly distensible wall creates a vital kinetic anchor.
The wooden block in the feather pillow.
Exactly. It provides the necessary focal resistance to capture thrusting energy and translate it into neurological pleasure, all while sitting within the massive balancing act of the pelvic floor's dynamic equilibrium.
It just fundamentally reshapes how we understand the mechanics of human intimacy.
It really does. And to wrap up this deep dive, I want to leave you with a final provocative thought that builds on everything we've explored today.
Okay, let's hear it.
We've seen how our ability to measure these internal forces is rapidly accelerating with real-time optical pressure sensors. As this mapping technology becomes cheaper and more precise, will the future of sexual medicine soon move entirely away from standard one-size-fits-all filler injections?
Well, that's an interesting thought.
Imagine a world just a few years from now where a woman's pelvic biomechanics, her exact angles, tissue distensibility, and structural deficits are digitally mapped in 3D during a simple clinic visit. Could we see a shift where doctors use that data to precisely engineer and 3D print personalized biomeshes or smart kinetic fillers?
Custom built for her exact anatomy.
Exactly. Interventions perfectly tuned to the exact mechanics of arousal and structural support for her unique individual body. The suspension bridge of the human body is vastly more complex than steel and concrete, and the tools we use to maintain it are about to become a lot more interesting.